Will I be able to get the seat of my choice? Will I be able to get good marks in the exam? Will I be successful? Do these things come in your mind often? Now, whenever these thoughts come to your mind, always remind to yourself that the results are not in your hands. They never were. What is in your hands but is to give your best effort. And there should be no compromise in that. You should have a long-term goal, and that should be there at the back of your mind. But what you have to focus on every day is your goal for that particular day. And why that day? The goal for that particular hour. Give your best effort to achieve the goal for every hour, for every day. And ultimately, why will you not be able to achieve the goal? Why will you not be able to achieve the seat of your choice? Why will you not be able to come out with flying colors? So just focus on your effort. Just forget about the goal. Do not worry about the results. Make sure that you give your best effort so that you do not have any regrets later. So with that, we start with a few congenital anomalies of the external nose. Now, yes, you asked me that is embryology of the nose important? The embryology of the nose has never been asked in your exams. So we do not consider that as important for you. But yes, there are a few congenital anomalies of the external nose which are asked in your exam. So we will be doing that. So one of them which is very, very frequently asked in your exam is choanal atresia. Now, you are first going to tell me what is the meaning of chona. Chona is another term for anterior nares, nasal cavity or posterior nares. Yes, very good. It is another term for posterior nares. So, again, that is a question that is asked in your exam, that what is chona. So, chona is posterior nasal apertures. Nasal apertures. So when there is atresia of the posterior nasal apertures, that is what we call as choanal atresia. Now let us quickly see why this choanal atresia develops. Now during development, there develops a depression which is known as the nasal pit. Now this nasal pit grows medially and this forms the nasal cavity. Now it further grows medially and it forms the part behind the nasal cavity. What is that known as? Nasopharynx. It is the part of the pharynx behind the nasal cavity, nasopharynx. So what we are seeing is that the nasal pit grows medially to form the nasal cavity and the nasopharynx. Now at the same time, just below the nasal pit is another depression. What is that? That is what is stomatodium. That also grows medially and that leads to the formation of oral cavity. And behind the oral cavity, what is that? Yes, that is oropharynx, the part of the pharynx behind the oral cavity. So that is oropharynx. So the stomatodium leads to the formation of oral cavity and oropharynx. Now please note here that the primitive nasopharynx is separated from the primitive oropharynx by a membrane. Can you see this? Yes, this membrane is what is known as the bucconasal membrane. Bucconasal membrane. And this bucconasal membrane, just see here, disappears. Yes, because of which in us, do we have the bucconasal membrane? Yes, after birth, does any child have bucconasal membrane? Yes, it usually disappears and the nasopharynx starts communicating with the oropharynx. Yes, so when this bucconasal membrane fails to disappear, then this is what we call as choanal atresia. So what is choanal atresia? It is persistence of the bucconasal membrane is what is choanal atresia. So yes, this is a question of your exam, that choanal atresia is because of persistence of which membrane. Okay, so now what will happen is that usually in us, the air that we breathe goes to the nasal cavity and then to the nasopharynx, and then it goes behind the palate, it goes to the oropharynx and then to the lungs. It goes down to the lungs. Now because of this choanal atresia, there is a block. So when the patient breathes, when the infant breathes, now this air is not able to go from the nasopharynx into the oropharynx. So what will be the complaint of the patient? Will all the patients of choanal atresia be having respiratory distress? Now just say here, choanal atresia can be unilateral, it can be bilateral, it can be complete, it can be incomplete, it can be bony, it can be membranous, it can be mixed. It can be mixed. Now, it is asked in your exam that what is the most common variety of choanal atresia? So, most common is the mixed variety. 70% is mixed. Mixed, what is mixed? Mixed is bony plus membranous. Whereas 30% is pure bony. 30% is pure bony. Now in this patient, what are you seeing here is, just see here, this is the septum. So these are the two posterior nasal apertures. What we are seeing is there is persistence of the bucconasal membrane only on one side. So this patient is having a unilateral choanal atresia. Will this patient have respiratory distress? No, this patient will not have respiratory distress. So yes, he will have nasal obstruction, and that also usually infants will not notice. It will be manifested later on. But if any infant has a bilateral complete choanal atresia, then how will that infant be born with? Yes, that infant will be born with respiratory distress. Both the posterior nasal apertures are closed. So you are posted in neonatology, and here is a child who is born with bilateral complete choanal atresia, which means that the child is born with respiratory distress. How will you know that this respiratory distress in the child is because of bilateral complete choanal atresia? Respiratory distress can be because of many other causes. Yes, that is something that you do in every child. What do you do? Yes, you pass a nasogastric tube through the nose and you see whether it is coming into the oral cavity. So if there is bilateral complete choanal atresia, what will happen? When you pass this nasogastric tube, you will not see it coming into the oral cavity. So you will confirm that yes, this is a child of bilateral choanal atresia. The child is in respiratory distress. Do something immediately. The child is having bilateral block. Yes, do something immediately. What? Intubation? Tracheostomy? Okay, just tell me, have you ever developed bilateral nasal obstruction? Don't tell me no. Sinusitis, bilateral nasal obstruction, yes or no? Yes. So what did you go for? Intubation or tracheostomy? None? What did you do then? Mouth breathing? Okay, then why not an infant? Why not an infant? Infants are obligatory nasal breathers. They cannot breathe. They do not know that if their nose is blocked, they can open their mouth and breathe. Yes, so that is why the child will have respiratory distress. In fact, this child, whenever the child is quiet, the child will have cyanosis. And then the child starts crying again and the cyanosis disappears. Again, there is cyanosis the moment the child stops. So now the child is in respiratory distress and you have confirmed that this is choanal atresia. So how do you confirm? Yes, so how do you confirm choanal atresia? By passing a nasogastric tube. Passing a nasogastric tube. And also what you know is that infants are obligatory nasal breathers. Infants are obligatory nasal breathers. They will not open their mouth and breathe. They are nasal breathers up till 4 to 5 months of age. So also sometimes in your exam is just given that an infant is born who is having cyclical cyanosis which relieves on crying. Yes, so this is an important thing that you should know, that there is cyclical cyanosis. Cyanosis which relieves on crying. The moment the child opens the mouth for crying, the child can breathe in now. So relieves on crying. So now what to do? The child is in respiratory distress. What will you do? Yes, what you need to do is just take a feeding nipple, make the bore of the nipple wide and insert it into the mouth of the infant. So now what will happen is that the mouth is kept open actively and the child will breathe through that. And that is what is known as McGovern's technique. So the immediate management is McGovern's technique. McGovern's technique, and later on, now the child is at least not in distress. So now you will take up the child for a CT scan to confirm whether there is choanal atresia or not. So what is this CT scan? What view is this? Yes, this is the axial cut section. So just notice here, this is the nose. It has been cut like this. So this is the nose that you're seeing, and here is the cheek, skin of the cheek. Here is the maxillary sinus, and these are the two nostrils. This is 1 and this is 2. Now just notice at the posterior part of the nostrils, can you see this? This is the corona, the posterior nasal apertures. Can you see that this is blocked? Yes, so this is depicting bilateral complete choanal atresia. So now you have confirmed that this child has bilateral complete choanal atresia. How are you going to manage this child? Yes, now you are going to post the child for excision. So that is the best management. Later on, the immediate management is McGovern's technique. Later on, you go for the definitive management, and that is excision. Now also notice that in infants already posterior nasal apertures are very narrow and you are operating in this narrow area. And when you are operating, what you are doing is you are automatically creating raw surfaces on both the sides. In the center is the septum. This is the lateral wall. You have cut the atresia segment in between. So there are raw surfaces on both the sides. So what will happen later on? Again, they will come together and there can be again synechiae formation. So it is always mandatory that whenever you operate in this area for choanal atresia, we use a drug to reduce synechiae formation, and that is what is asked in your exams. So what is that drug? Yes, we give mitomycin C. Mitomycin C is used in other places also in the nose. It is used in the larynx also. When we come to that section, you are going to tell me that we were using mitomycin C in choanal atresia. Yes, you will tell me? Yes, you will have to tell me. So what this mitomycin does is it prevents synechiae. Now, another important thing to remember in choanal atresia is that there is an association of choanal atresia with the charge syndrome. What is charge? C-H-A-R-G-E. What is this? Each of this stands for something. What is C? C is coloboma. Coloboma of the eye, and C also stands for cranial nerve abnormalities. Cranial nerve abnormalities. H is heart defects. Heart defects. A is, what do you think A is? A is choanal atresia, atresia of the choana. A is atresia of choana. So R, what is R? R is retarded growth and development. Retarded growth and development. G is genitourinary defects. Genitourinary defects. And what is E? What do you think is E? E is esophageal abnormalities? No, it is ear abnormalities. So yes, when in your choice is given esophagus, you think, okay, charge has E, it must be esophagus. No, it is not esophagus. It is ear abnormalities. Ear abnormalities. Okay, so now quickly tell me, what is choana? Choana is another name for? Yes, for posterior nasal apertures. Choanal atresia is because of persistence of, very good, bucconasal membrane. A child is born with bilateral complete choanal atresia. What will be your immediate management? McGovern's technique. What is more common, membranous or bony? 70% is mixed. 30% is pure bony. So what is the definitive management of choanal atresia? Surgical excision. What is the drug that you use to reduce synechiae or to reduce fibrosis? Yes, mitomycin C. And is esophagus a part of the charge syndrome, esophageal abnormalities? No, what is E? E is ear abnormalities. Now we have another congenital abnormality that is asked in your exam, and that is this. What do you think this is? Yes, this is how a meningocele or a meningoencephalocele appears like. So whenever there is a defect in the base of skull, we know that the roof of the nose is the base of skull. So whenever there is a defect in the base of skull, there occurs herniation of the brain tissues. So there can be herniation of just the meninges. When it is just the meninges, then it is what is known as meningocele. Meningocele. It is just meninges. Just meninges. And if it is meninges plus brain tissue, then that is what is known as meningoencephalocele. Meningoencephalocele. So just see here. Yes, can you notice here that there is herniation? There is a defect in the base of skull here. Because of this, there is herniation of the meninges along with the brain tissue. Can you notice here? Yes, so this is what is known as meningocele or meningoencephalocele, and this has to be differentiated from another condition which is known as glioma. Now, what is the difference between meningocele or glioma? Yes, in meningoencephalocele or in meningocele and in glioma. In glioma, what happens is that this intracranial connection gets obliterated. So, you will see the external mass, but the connection between the mass and the brain tissue will be absent. There can be a stalk connecting it, a fibrotic segment, but there will be no open connection between the mass and the intracranial tissue. That is what is known as glioma. So you need to differentiate when you see a picture like this, whether this is a glioma or it has an intracranial connection. So now let us see how we differentiate. We can differentiate it by many points. So yes, the intracranial connection is present in encephalocele, whereas it is absent in glioma. Glioma, yes, it just contains glial tissues, no intracranial connection. Now, how on examination you can find out whether it is glioma or it is encephalocele? So, on compression, encephalocele is compressible. It is compressible. It is soft. Just the appearance also can tell you. It has a bluish appearance. And it is pulsatile. Whereas a glioma is firm. When you touch it, it is firm. This is firm. And this is not compressible. It is not pulsatile. Now, the Furstenberg test, what is Furstenberg test is that whenever the child cries, you see that this mass enlarges. Yes, so whenever the intracranial pressure increases, you can see the increase of the intracranial pressure getting transmitted to the mass. So now that I've told you what Furstenberg test is, can you tell me it will be positive in what? Whether it will be positive in glioma? Will it be positive? No, because the intracranial connection is obliterated. So here it will be absent. So in Furstenberg test, you can also test it by occluding both the jugular, internal jugular, to increase the intracranial pressure. But yes, in children it is very easy. The child will cry and you can see the mass enlarging. So Furstenberg test will be positive in encephalocele. And encephalocele will always be transilluminant. When you just put a light on it, it will just light up like a bulb. So transillumination will be present, whereas glioma, it will be absent. Now, the most common site of encephalocele is occipital. Occipital is the most common site. This is the most common, followed by frontal. Whereas gliomas are 60% they are present here extranasal. 30% is intranasal, and 10% is mixed. Now, if in your question is given, one of the choices is that recurrent meningitis, CSF leak, CSF rhinorrhea is a feature of glioma. Will that be true or false? Yes, that will be false. Why? It is seen in, yes, it will be seen whenever the intracranial connection is there. Yes, so it will be seen in encephalocele. Recurrent meningitis. Nose is an area which can get infected very commonly. So now the infection through that defect in the base of skull can very easily reach the intracranial part. So there can be recurrent meningitis. There can be CSF leak, CSF rhinorrhea. Whereas all this can be absent here. So always we need to remember, if any infant you are seeing with a polypoidal mass in the nostril, yes, do not think that this is polyp and let me just take a biopsy. Always remember, polyps are not seen in infants. When we do nasal polyps, we will again see this there, that polyps are never seen in infants. At this age, polyps are not present. So if you're seeing any polypoidal mass in the nose of an infant, what is the thing that should come to your mind first? Yes, this can be a meningocele, this can be a meningoencephalocele, and then you will have to go for a MRI. You will have to go for a CT to confirm. Both CT and MRI. CT will show the bony abnormality and MRI will show the intracranial, whatever the herniation has occurred and what the intracranial defect is. So you will have to go for that to rule out whether it is a meningocele or not. So here this is a polypoidal mass. intranasal, on anterior rhinoscopy or an endoscopy, what you see is a polyp. So always rule out a meningocele here. And once you have confirmed by MRI, you can see the defect and you can see the herniation. Now you have confirmed that this is a meningocele or meningoencephalocele. What you now go for is excision of this. So what you do is you excise all the non-functional brain tissue. Usually the brain tissue which has herniated out is non-functional. So you excise that and you close or you reposit whatever is functional and you close the defect. So what you do is excision and closure of the defect. Closure of base of skull defect. This is for meningocele or meningoencephalocele, whereas glioma you can just excise the mass. Whereas glioma is just excise the mass. So here is a child where you are seeing a mass here, extranasal mass, and that mass is increasing on crying. What is that? Encephalocele or is it a glioma? Okay, it is encephalocele. Okay, it is a very firm mass, not transilluminant. Then it is, yes, it is glioma. A child presents with an extranasal mass and there is a recurrent history of meningitis. Then this can be a meningoencephalocele. So having done the important congenital conditions in relation to the external nose, now let us start with the anatomy of the external nose. Now what do you think, external nose is mainly cartilaginous or mainly bony? You have the nose, no? Feel and tell me. Yes? Yes, it is mainly? Yes, it is mainly cartilaginous. Yes, which part of your external nose is bony? Just feel and tell me. Yes, it is only the upper 1/3. Only the upper 1/3 which is bony. The lower 2/3 is cartilaginous. Am I right? Can you feel also? Is it the same? Yes, the upper 1/3 is the bony part, lower 2/3 is cartilaginous. Now, in the bony part, we have these two bones. Guess what are these two bones? These are the two nasal bones. And just lateral to the nasal bones, we have some process of this bone. What is this? Maxilla. Some process of maxilla coming up. This is what is known as the frontal process of maxilla because it goes up to articulate with the frontal bone. So we have these two. These are the two nasal bones. Okay, so these are the two nasal bones. And just lateral to them, this part, this is the frontal process of maxilla. The frontal process of maxilla. And they articulate above with the nasal process of the frontal bone. Which bone is this? This is the frontal bone. The nasal process of the frontal bone. The nasal process which comes down. So here this bone that we are seeing, this is the nasal process of frontal bone. So now quickly you're going to tell me what are the parts of the external nose, the bony parts of the external nose. Yes, we have the two nasal bones, we have the two frontal process of maxilla, and we have the nasal process of the frontal bone. Now coming to the cartilaginous part of the external nose. In the cartilaginous part of the external nose, we have this cartilage. What is this known as? Yes, this is known as the alar cartilage. Now this alar cartilage is actually a U-shaped cartilage. Just see here. It is in the form of a U. It has got a lateral crus which forms the external nose and a medial crus which forms a part of the septum. The medial crus forms a part of the septum. So here, when we see the external nose, this is what is the alar cartilage. Now just feel your external nose and let me know that above the alar cartilage, do you have another cartilage or is it articulating? Is the alar cartilage articulating directly with the bone above? Yes, there is another cartilage above. So this alar cartilage is the lower cartilage. This is the upper cartilage. So hence is the name. This upper cartilage is what is known as upper lateral cartilage. This is known as upper lateral cartilage. Whereas this alar cartilage is what is known as lower lateral cartilage. Lower lateral cartilage is the alar cartilage. The alar cartilage, which part of alar cartilage? It is the lateral tour of the alar cartilage. Now we have another paired cartilage in the external nose, and where is that? Just see here. Can you see the small cartilage here? Yes, this is what is known as the sesamoid cartilage. This is known as sesamoid. Sesamoid cartilage. So on the external nose, we have these cartilages and all of them are paired. So these are the paired cartilages of the external nose. Now in the external nose, we have another cartilage and that is unpaired. Now when I say another cartilage, you must be thinking that where is the space for another cartilage here? It is already filled. Yes. So yes, we have another cartilage that is unpaired and that is the septum, the septal cartilage. But septal cartilage is inside the nostril. Where is it on the external nose? Yes, just note here. The dorsum of the septal cartilage projects to form the dorsum midline of the dorsum of the external nose. So this septal cartilage is what forms the unpaired cartilage of the external nose. Unpaired cartilage of external nose. So in the cartilaginous part, we have the various cartilages. Yes, quickly you're going to tell me what are these cartilages. Yes, how many paired cartilages? Yes, 3 paired. What are 3 paired? The upper lateral. Yes, you have to tell this. This is for you. Yes, the upper lateral, the lower lateral and the sesamoid cartilage. And which is the unpaired? Unpaired is the septum. Now on the external nose, where there are intersection between the frontal bone and the nasal bone, between the nasal bone and the cartilages, between the two cartilages, upper and lower lateral, these intersection areas have been named and they are asked in your exam. So what are the names given to them? We need to know the junction of the frontal bone with the nasal bone. So this area, this is what is known as nasion. It is known as nasion. Now the junction of the bone with the upper cartilage, upper lateral cartilage, this is what is known as rhinion. So how do you remember? In common parlance, we call it as nose, and in specialized, we call it as rhinology. Yes. So N is the upper part, that comes first, and R, rhino, is later, that is more specialized, so that is the lower part. That is how you have to remember. Now we have another intersection area and that is the junction of the upper lateral with the lower lateral. What is that area? Can you see this area? Yes, this area is a very, very important area on the external nose. What is this area? This is what is known as Lyman nasi. Lyman nasi. And why is this Lyman nasi important? The Lyman nasi is it forms a part of the nasal valve area. So what exactly is the nasal valve area? The nasal valve area is the narrowest part of nasal cavity. It is a very, very important area in the nose, and that is the narrowest part of nasal cavity. And where is it exactly? Yes, so exactly if you want to see on your external nose, that is the area that coincides with the dip that you see on the external nose. Do you see a dip on the external nose here? Yes, that is exactly the area of the Lyman nasi. The Lyman nasi forms the lateral boundary of the nasal valve area. Now we will just see the boundaries of the nasal valve area. So laterally we have this Lyman nasi. Yes, in the center where this meets the septum, that is the medial boundary. And when we go intranasally, yes, when we go through the nostril inside, just on the inner surface of the Lyman nasi, we have a turbinate. Which turbinate? The inferiormost turbinate is the inferior turbinate, which means that this area is the area of the Lyman nasi. What is the Lyman nasi exactly? Yes, it is the lower border of the upper lateral cartilage, or it is the intersection between the upper and the lower lateral cartilage. Now, why is this area the narrowest? Because the upper lateral cartilage, the lower border of the upper lateral cartilage, it projects inside the nose at this Lyman nasi area. So laterally we have the Lyman nasi. In the center we have the septum, and when we see through the nostril inside, we have the inferior turbinate. So if you see here, so this here is the area of the upper lateral cartilage. Yes, this is the area of the lower lateral cartilage. So this here is the area of the Lyman nasi, or we can call it as the lower border of the upper lateral cartilage, because that is the one that dips inside, making this area narrowest. So if I now rub it, now what you are seeing is the inside of the nose. So here laterally also what we are seeing is the inferior turbinate, the anterior border of the inferior turbinate. So if we are going to write down the boundaries of the nasal valve area, which is asked in your exam, so what will be the boundaries? Yes, laterally is this area. So what is that laterally? Laterally you can call it as Lyman nasi. That is the intersection between the upper and lower lateral cartilage. Lyman nasi, or sometimes Lyman nasi is not given in your choice. What is given is the lower border, lower is also known as caudal border of upper lateral cartilage or lower lateral cartilage. Yes, of the upper lateral cartilage. And laterally also we have this turbinate here. Which turbinate is that? That is the inferior turbinate. So laterally is this complete? Yes, laterally is also the inferior turbinate. Inferior turbinate. In the center we have the septum. In the center is the septum, that is the medial wall. Medial wall is formed by the septum. And below we have the floor of the nose. So inferiorly we have the floor of the nose. The floor of nose. This is what is known as the internal nasal valve. Internal nasal valve. Internal nasal valve. And what's the significance of this? This is the narrowest part of nasal cavity. Narrowest part. Narrowest part of nasal cavity. Now, if I tell you that this is internal nasal valve, it means that there is something that like external nasal valve also. So what is external nasal valve? This external opening. This external opening of the nose is what is known as external nasal valve. So if I draw it here, this opening, this is what is known as, this is the external nasal valve. This is external nasal valve. Now, external nasal valve is not asked in your exam. What is asked in your exam is the internal nasal valve. So, is it very clear what the internal nasal valve is? Yes, the internal nasal valve is formed laterally by limen nasi or the lower border of which cartilage? Upper lateral cartilage. In the center, we have the septum. In the center, we have the septum. And also on the inner side, we have which turbinate? Laterally, yes, we have the inferior turbinate. Now, why is this so important? Why is this asked so commonly? I hope you have understood what this nasal valve area is. Yes, why is it asked so commonly? This is the narrowest part of the nasal cavity. So what? Yes, just understand this here. So what is the significance of the nasal valve area? Yes, what is the significance of the narrowest part of the nasal cavity? Yes, this offers maximum resistance to nasal airflow both during inspiration as well as during expiration. So what happens during inspiration? Whenever we are breathing in the air encounters a sudden resistance at the nasal valve area. So there is a sudden resistance at the nasal valve area, because of which the velocity of the air goes down. And when the velocity of the air goes down, the air gets enough time to come in contact with the mucosal surface of the nasal cavity. And why is that important? Yes, have you noticed that whenever you are breathing through the nose, no matter how hot the external air is, how cold the external air is, or how dry the external air is, you do not feel any scratchy throat, you do not feel any dryness of the throat when the air goes through your throat to the lungs. Whereas if your nose is blocked and you open your mouth and breathe, yes, the throat feels very scratchy, the throat feels very dry. Why? Yes, because in the time that the air takes, in just 1/4 of a second that the air takes to reach from the external nares to the inside to the posterior nasal apertures, in that much of time the temperature of the air gets regulated to body temperature. The humidification of the air occurs. And why does that occur? Yes, that occurs through the nasal mucosa. So that is why this nasal valve is very, very important for temperature regulation and for humidification. So that is during inspiration. During inspiration, what happens because of nasal valve area is temperature regulation and humidification is assisted. Why? Because of the sudden slowing down of the air and humidification. And what happens during expiration? Now, during expiration, when we are breathing out, because of the narrowing at the nasal valve area, that is at the level of the inferior turbinate. We have seen that at the level of the inferior turbinate. Yes, so what happens is that because of the sudden resistance that is offered here, reverse currents are formed, and these reverse currents are known as eddy currents. And why are these reverse currents important? Because these reverse currents then go into the sinuses to ventilate the sinuses. They go to ventilate the sinuses. So yes, this is asked in your exam that ventilation of the sinuses occurs during inspiration or expiration. Yes, it occurs during expiration. And it occurs during expiration. Why? Again, it is helped because of the narrowing at the nasal valve area. So here we need to know that the ventilation of sinuses occurs during expiration. So which means that if by chance you develop sinusitis or somebody in your house has sinusitis and you are asking that patient to take steam, how will you ask that patient to take steam? Inhale through the nose and exhale through mouth. Take steam also and waste your time also? No, inhale through the nose and exhale also through the nose. Why? Because by steam, what are we wanting? We are wanting the humidification of the sinuses. Yes, so inhale through the nose and exhale through the nose. Why? Because the ventilation of the sinuses occurs during expiration. Now, another clinical significance of the nasal valve area is that this is already a very narrow area. Now, if there is a little deformity of the septum also in this area, very mild deformity of the septum, it will lead to a lot of nasal obstruction in the patient. So, patient will come with nasal obstruction. When you do anterior rhinoscopy and see, you see that there is hardly any deviation. So, if there is any deviation of the nasal valve area, yes, it is possible that the patient, in spite of small deviation, will have a lot of nasal obstruction. And how can you test that this is because of the nasal valve area? So yes, what you can do is you can ask the patient to pull the cheek upward and laterally. So when you ask the patient to do like this, what happens is that the lateral part of the nasal valve, what is that? The limen nasi, yes, that is pulled laterally. So when that gets pulled laterally, the space is created in the nasal valve area. So if it is because of nasal valve area obstruction, nasal valve area further narrowing, then there will be a relief of nasal obstruction by doing this. And this test to test the patency of nasal valve is what is known as the Cottel's test. Cottel's test. Yes, we will do this test again later on when we do the septum. Yes, but now that we are doing the nasal valve area, we have to know this test. Yes, this is asked in your exam. So yes, do we know the external nose? Do we know the external nose? Yes, which part of the external nose is bony? Upper 1/3. Which part of the external nose is cartilaginous? Lower 2/3. How many paired cartilages do we have in the external nose? How many paired cartilages? Yes, 3 paired cartilages. What is the unpaired cartilage of the external nose? Unpaired is the septal cartilage. What is the sesamoid cartilage? Is paired or unpaired? Yes, it is paired. Is the nasal bones paired or unpaired? Yes, it is. It is paired. So what is the narrowest part of the nasal cavity? Nasal valve area. Quickly tell me the boundaries of nasal valve area. Boundaries of nasal valve. Lateral is limen nasi. It is the limen nasi. If limen nasi is not there in the choice, then yes, upper border of lower lateral cartilage or lower border of upper lateral cartilage. Yes, the lower border of upper lateral cartilage. So laterally we have the limen nasi, the inferior turbinate, and in the center we have the septum. And this angle is very narrow. It is just around the nasal valve area angle. The nasal valve angle is just around 10 to 15 degrees. It is very narrow, just 10 to 15 degrees. What is the test to test nasal valve area? Yes, it is the Cottel's test. What's the most prominent part of your face? Yes, the external nose. So which means that the injuries of the external nose will be very common. Yes, whether a person falls down from front or whether there is a blow from external from the lateral side or there is a hit on the face, the most common part to be injured is the external nose. So that is why deformities of the external nose are seen commonly, and these deformities can be classified according to whether the tip is deviated, whether the dorsum is deviated. So let us see what the deformities of the external nose can be. So now just see here, what we are seeing in this patient is that just see the tip of the nose is in midline, whereas the dorsum is deviated like this, something like an S. Yes. Now also see here. Yes, what are you seeing here? Again we are seeing is that the tip is in midline but the dorsum is deviated something like a C. Yes, so whenever the tip is in midline but the dorsum is deviated, this is what we call as the crooked nose. Crooked. And yes, it is asked in your exam, what is crooked nose? So crooked nose is when the dorsum is deviated. Dorsum is deformed. It can be either C shape, it can be S shaped, but tip is in midline. Whereas if the dorsum as well as the tip both is deviated to one side, that is what is known as deviated nose. When the tip is not in midline, that is what is known as deviated. Deviated means dorsum and tip plus tip both deviated to one side. Deviated. Now there is another deformity, and what is this? Yes, we can see that the nose is humping. So this is what is known as hump nose. Hump nose. And for all the deformities of the external nose, what is the surgery that we do? Yes, a very common surgery. All of you want to get it done. What is that? Yes, the rhinoplasty. Even if the nose is normal, then to beautify it. Yes, the rhinoplasty, plastic repair of the nose. So the management of all external deformity is rhinoplasty. And if there is deformity of the septum also, for example, when we are seeing this patient, the septum is also deviated. So then we also have to go for a septoplasty. Septoplasty. So rhinoplasty with or without septoplasty. Now what is this deformity that you are seeing? Yes, this what you can see is a saddling of the nose. So this is known as saddle nose. Saddle nose. Now rest all the deformities were caused most commonly by trauma, but this saddle nose is a very important deformity. And why is this important? Because this is usually not caused by trauma. It can be caused by trauma also, but the important thing about saddle nose is that mostly it is not by trauma, it is by what? Saddling of the nose shows you that the support of the nose. What is the support of the external nose? Yes, the septum inside. The septum has got damaged. Yes, and that indicates that it can be any granulomatous condition. So any patient that you are seeing with a saddle nose, very, very important, you have to investigate the patient for granulomatous condition. It can be TB, syphilis, lupus, leprosy, or vagus. Vagus now commonly it is known as, yes, it is known as granulomatosis polyangiitis. So if this picture is given and it is asked a diagnosis, then any of the granulomatous choices, conditions that is given in the choices, you can mark that as the answer. So this here, the patient should be investigated for granulomatous condition. Granulomatous condition. So do we know the cartilaginous framework of the external nose? Yes. Do we know the bony framework of the external nose? Do we know the intersection areas? Now, when I'm telling you, asking you this, then all this should immediately come to your mind. Yes or no? Yes. What is this area? This is rhinion. This is nasion. This is? Yes, this is nasion. What is the narrowest part of the nasal cavity? Nasal valve. What is the angle of the nasal valve? It is 10 to 15 degrees. Why is nasal valve important? Do we know that? What's the test for nasal valve? Yes, the Cotter's test. When the tip is deviated along with the dorsum, what is that known as? That is known as deviated nose. Then what is crooked nose? Crooked nose, tip is in midline. Only the dorsum is deformed. And any patient of saddle nose, you will investigate for which condition? For granulomatous conditions of the nose.